Right now, we know that our experiences shape our perspectives, and we know that COVID-19 has really kind of influenced how many of us are starting to think about the long-term care that we want to have in Canada. And we know that right now, for many older Canadians, accessing care usually means having to leave one's home or community. And again, leaving one's community and being institutionalized and not being able to receive culturally safe and appropriate care close to one's family and friends is unfortunately a reality for many people, especially those living in northern, rural, and remote communities and our Indigenous communities. And there also exists a universal desire to age in place amongst most older Canadians. And so how do we enable this across Canada? We know that when we specifically look at how COVID-19 has shifted our perspectives, we've done a number of surveys now. We did one in partnership with TELUS Health. We did another in partnership with the Canadian Medical Association. And we also did another one specifically in partnership with the National Bank. And when we looked at the data, again, some of this is Ontario focused, but others is looking at Canada in general. We know that when you start looking at what people were talking about, most people, and this is mostly Ontario data here I'm showing right now, show that Ontarians believe that there's a crisis in long-term care, that most say they would prefer to receive home care for themselves and their loved ones over care in a long-term care home. When we did our national survey, we found that 68% of Canadians and almost 70% of Canadians 65 and older reported that the pandemic itself and COVID-19 has changed their opinion on whether or not they'd arrange for themselves or a loved one to live in a nursing or retirement home. But surprisingly, the majority of people do not believe that they'll have access to good quality long-term care when they need it. And when we looked at the desires of Canadians in general, we found that virtually nearly 100% of Canadians who are older Canadians want to stay in their own homes for as long as possible. So how do we reconcile these desires with the realities that actually exist right now within our system? But also our realities need to be respected. And when we think about Canada as a whole, we have to remember that small, remote populations often do not have the support or do not have the economies of scale and that are actually needed, for example, to actually deliver, traditional what's considered long-term care by building large institutional care settings, for example. And as long as we look at rural problems with urban solutions, we're going to miss opportunities that also exist to really think about long-term care that really is designed to meet the specific community's needs. And if any of you are following the literature on what has been happening in Nunavut, for example, over the last decade, we'll realize how they've really struggled when they've tried to think about applying kind of traditional models of long-term care in their settings, which has sadly resulted in many people in Nunavut having to fly down to live in a retirement home in Ottawa to receive their long-term care, and not an ideal solution that you may have read about in the Globe and Mail as well. So again, we're struggling with these issues across Canada. I think we're struggling with these issues in Ontario, but also in BC. I think many of these issues resonate wherever you are across the country. This was the oldest respondent who actually participated in my work developing Ontario's senior strategy. This is Granny Wabanow. She was actually the oldest residential school survivor in Canada at the time when Prime Minister Harper actually delivered an apology to our Indigenous communities across Canada for the residential schools issues, if you will, and tragedies, frankly. And Granny was 107 years of age at the time when she participated in our consultation work up in her community of Moose Factory, Ontario. And when I asked her, just like I asked so many other people, what matters most to you, she said, I just want to have services available in my community so I'll never have to leave it. And we were able to develop services in her community that allowed her to age in place and to die in her community, which was her wish at the tender age of 109 years of age. So again, when you actually think about what people want, whether they live in rural and remote communities or they live in downtown Vancouver, for example, often we'll find that people's attitudes and ideas are pretty similar and universal. The question is, why are we not doing more to enable that? So when we think about enabling the future of long-term care in Canada, we have to kind of contextualize this amongst other things that we need to tackle to meet the needs of an aging population. And so our research institute, the NIA, has done a lot of work on this. And these were two seminal reports we published actually in the fall of 2019, right before the pandemic. One that gave a new overview of kind of what long-term care provision looks like across Canada and what needs to be done, and other models from around the world. And then the second paper really costed out what long-term care currently costs in Canada and what it will look to cost it out by 2050 if we continue with current trends. And this follows kind of some of that one specific pillar of work, what we call care closer to home, which is part of our work around the idea of a national senior strategy. So again, you can see how this fits into a much broader framework when we think about how do we promote healthy aging, how do we think about caregivers and their needs, and how do we think about care closer to home. And so I think this is an important area to discover and think about within the context of other issues. So when I think about long-term care, the challenge is that in many parts of Canada, long-term care actually means nursing home care, if you will. Whereas if you actually go on the global stage, if you look at a lot of other countries around the world, long-term care is generally, referring to long-term care, mainly for principally older people who might need different types of support that could be provided either in a long-term care home, if you will, a nursing home, or in their own homes in their communities where they live. And so we really kind of crafted a definition to really frame the work that we were doing here in Canada that focused on the provision of care and supports that might be supports with one's IADLs or ADLs, so those basic functional tasks that might be might be delivered by either a paid care provider or unpaid caregivers. We look at where that care can be provided, and we also look at how that care can be both preventative and responsive in nature as well. And so this is kind of, again, how we can start framing what long-term care can look like as we see it across Canada. And so why does long-term care matter? Well, right now it's the largest form of hands-on care that's not covered under the Canada Health Act. I think that's something that we have to actually be really mindful of. Right now, you may have heard that our federal government has talked about the creation of a new Safe Long-Term Care Act. And people wonder, how will that be different to the Canada Health Act? Because right now, the Canada Health Act doesn't cover the provision of long-term care, which would include, as I'm talking about, nursing home care to home and community care. And so if it's not about reopening the Canada Health Act, what does the Safe Long-Term Care Act actually look like, and what would that actually cover? Because right now we know that coverage levels, qualifying criteria, and design standards vary significantly across our provinces and territories. And we also know that there's a growing value of these services to meet the long-term care needs of our aging population effectively and sustainably as well. And so we know the current demand for long-term care services is already unprecedented and is only expected to grow. But we know that our system has been plagued with long-standing systemic vulnerabilities when it comes to health human resources and physical design and redevelopment approaches. And I know that I only caught the tail end of my colleague, Dr. Estabrooks's talk, but again, she was talking about things that she has been researching and understanding for years with her team through the University of Alberta. So what we know is that right now, when we've done various surveys, and there are many surveys that have been looking at aspects of long-term care, a 2015 survey found that 63% of respondents said that their family was not in a good position, either financially or otherwise, to care for older family members if they needed long-term care. And this actually worried them greatly. So we know that many people are struggling right now in terms of just thinking about, if my family member needs this, how am I going to provide that support? We also know that through other surveys that are over 430,000 Canadians that currently have unmet home care needs. And at that time in 2019, there were over 40,000 Canadians who are on nursing home wait lists. That number during the pandemic has now climbed to over 52,000 people. So we know that obviously if people can't get their basic care needs met at home in their communities, that is going to drive a huge demand for long-term care or care in long-term care or nursing homes as well. And so obviously, if we can better meet the needs of people in their own homes and communities, we probably wouldn't have such a massive waiting list. We also have to contextualize how we're performing, in our country versus other countries around the world, for example. And right now, when you look at this particular slide, that looks at Canada versus other OECD nations. To help orient you, I'm going to see if this pointer, this laser pointer scheme works. So hopefully you'll see this. But what you can see right now is Canada's indicated here, kind of close to the middle by a maple leaf. That means 1.2% of our GDP is spent providing long-term care services. So it's higher than other countries, for example, like the United States, which spends half of what we do. But then when you look to the towards the extreme here, you'll see countries like Denmark that were spending 2.5% or twice what we were spending. And right now we are currently 30% less than the OECD average. So the average of kind of the countries that we're comparing ourselves to, which are other kind of generally well-off industrialized nations. When we actually look at this next slide here, we also look at where we're spending our dollars. So again, to orient yourself from the left, you'll see over here that we're spending about 87 cents on every dollar caring for people in long-term care homes or nursing homes, and only about 13 cents of every dollar on home and community care. Some more recent data that came available more recently, that was also published by CIHI, show that that provision is now kind of improved, where it's about 2/3 of spending on nursing home care and 1/3 spending on home and community care, representing some greater investments in the home and community care sector, which then brings us to kind of where we are on average with the other OECD countries. But again, you remember I pointed out Denmark that spends twice of their GDP that we do on the provision of long-term care. Well, look at Denmark over here. Not only are they spending twice of what we're spending of their GDP, but 2/3 of their spending is around the provision of home and community care. Only 1/3 is around the support of people in nursing homes. So a real completely different paradigm shift, and we'll talk about Denmark again in a little bit. So my colleague Bonnie G. McDonald also did the first study that actually looked at what our current costs are in the provision of long-term care and where those costs will be by 2050, for example. And this is kind of the idea that if we do nothing differently, if we just keep increasing our costs to meet the needs of our aging population, the blue here, to orient you, represents spending on nursing home care. The green represents spending on home and community care. And this overall total of the blue and green represents long-term care spending. But what you can see right now is to meet the needs of our growing aging population, remember that 10 years from now, by 2031, 1 in 4 Canadians will actually be an older person. Our baby boomers will start turning 85 in 2031. And then all of a sudden, you can see there's going to be a big acceleration to meet the needs of an aging population. And if we continue spending the majority of our dollars warehousing people in nursing homes, if you will, then you can see that the costs are going to escalate much more quickly, to the point that what we will be spending on publicly funded long-term care will actually represent 1 out of every 5 public federal or provincial personal income tax dollar. So these are costs that are growing at an exponential rate. And the question is, how are we actually going to meet these costs if we continue doing through taxation, public taxation as well? So again, to summarize that here, we know that between 2019 and 2050, the cost of public care in nursing homes and private homes will more than triple from 22 to 71 billion in 2019 dollars. Now, of course, you can kind of say, well, governments might simply say, well, we'll just put more effort onto families because families will just pick up the slack. We always have lots of daughters around who will always just fill in the gaps. So that's what we're going to rely on. Well, what we did was we also looked at the trade-offs that will not work, if you will. And we have to remember that between 2019 and 2050, there will actually be 30% fewer close family members available to provide unpaid care. Why? Because we have declining birth rates as well. And so we're going to have fewer family members around, especially when more people are living further away from their parents, to be able to provide unpaid care. And so those remaining family caregivers who are available will have to increase their level of productivity by 40% just to actually meet the current level of unpaid care that is being provided for our older population. So again, this just shows us and reminds us that it will be unsustainable for us to think that we can just shift more onto families to fill in the gap, given that right now they're providing approximately 90% of the home and community care that is being provided currently in Canada, and from that perspective. So when we start thinking about how do we start measuring and how do we start thinking about a framework that supports the future long-term care provision in Canada, we have to think about kind of a model of care that really thinks from this notion of how do we start thinking about people when they're healthy, older adults with minimal care needs, all the way to people who might have extensive care needs that will require them to actually live in a long-term care home setting, for example. And what does that care need to look like? And we think about everything that we can do along the spectrum. And so that report that I talked about, Enabling the Future of Long-Term Care, really detailed this model out in particular and really goes through kind of each of these kind of 4 levels, talking about innovative things that are happening in Canada, but also around the world in countries like Denmark, but in the United States and in other jurisdictions, where there are actually really great, innovative, sustainable, and smart ideas that are cost effective that could allow us to support more people to actually age in the right place, if you will. And so I think these are things that we need to think about. I know my colleague and friend Candace Chartier, who's now in BC and leading the work at Providence Living, may have already or will be talking about some of the great work that they're leading around developing dementia villages, for example, and looking new models of long-term care. Because I want to make it very clear, I'm not saying that we shouldn't have long-term care homes, but currently the current models that we have are not really helpful in terms of meeting in being pandemic ready, for example. So I want to show you an image from what we call a greenhouse. This is an innovative model of long-term care that's been developed in the United States and has been replicated in small bits and pieces in Canada. There are no official greenhouses in Canada that we know of, for example, but the idea is that you actually have a long-term care home that's built as a small home-like setting. So in a typical greenhouse, you might have, it looks like a large home. It has a large, kind of family room and common kitchen areas you can kind of see. And then each of the 12 residents will have their own private bedroom, their own private bathroom, for example. And again, when you think about the settings that we want to care for people in, how do we think about physical distancing considerations? How do we think about easy to clean surfaces? How do we think about new settings that eliminate 2, 3, and 4 bedded layouts? Ontario, which had up to a third of its long-term care residents living 4 to a room, has now banned that and basically said that they'll cap capacity at 2 people in a room. But then you have provinces like Alberta that basically have said, from what I understand, that they're eliminating even multi-bedded rooms, that they're going to keep people 1 to a room moving forward. But then how do you also think about smaller footprints and common staff? Right now, Ontario is on a rapid rampage to build 30,000 new long-term care beds. We've got our premier currently running around showing these big new modular homes that have 324 beds, if you will, some in double rooms, for example. They look rather Spartan, warehousey-like, and they're really heralding that they can build these things within 13 months, really, to pack people in. But you really think about this notion, and then you think about the evidence and literature talks about having smaller footprints, with common staff. And always making sure that first and foremost, we remember that these homes are actually homes, that they need to be home-like, and not institutional in nature. And we've heard that loud and clear through the work that we've been doing in developing new national long-term care standards. Speaking of which, I want to speak a little bit about that because that was my reason to be here today. So I want to give you a little overview of what's happening for those of you who may not be familiar with the work. So in response to everything that we've been learning through the COVID-19 crisis, after our first wave, Canada sadly had the dubious distinction of having the highest rate of its deaths occurring in any OECD country in long-term care. 81% of Canada's deaths as of May or June 2020 had occurred in its long-term care home and retirement home settings, for example, and that was twice the international OECD average. So we were leading the world, but not in something that we'll be proud of. And then this started a conversation federally where the federal government started saying, maybe we do need national standards, for example. And so in the fall of 2020, the government's throne speech talked about working with the provinces to develop new national long-term care standards. And so in response to that throne speech and that proclamation, the federal government actually has one of its crown agencies is called the Standards Council of Canada, and the Standards Council of Canada oversees the development of any national national standard, if you will. So the SCC invited standards development organizations from across the country to actually engage in helping develop new standards. HSO already had an existing long-term care services standard that had been in existence since about 2014, but HSO standard always has focused on the care that's being actually provided in a care home, for example. It doesn't actually go into broader issues of looking at the operation and design, if you will, of care homes in particular. And so CSA Group also put together a proposal with HSO saying, we'll develop two complementary standards, an updated HSO standard and a brand new CSA standard that would help to comprehensively provide standards around what we'd call the software, the care that's actually happening in a care home, but also the hardware. How does these homes need to look? What ideas should they actually follow? And what I just talked about is largely in line with what CSA has proposed in their draft standard that's out currently for public review. I'm going to speak specifically about the HSO standard, and the HSO standard is going to be focused on the idea of resident-centered care practices, the provision of safe and reliable high-quality care, the idea of how do we create a healthy, competent, and resilient workforce, and finally, the idea of creating strong governance practices and operations. So this is kind of what, the idea that the software, if you will be focused around. In terms of where are we at on the timelines, both HSO and CSA are working on common timelines. Right now, the public review process has just closed for HSO on March 27th. CSA's public review process will close on April 11th. But I will share with you a little bit of data on how things look. But I just want to walk you through our overall timeline here so you appreciate the work that's actually been happening. Just over a year ago, when it was announced that HSO and CSA were developing the new national standards, both organizations had an open call to establish their technical committees. We had hundreds of applications from folks who want to serve on our technical committee, and I'm proud that we chose 32 members, some who are Carol Ward, Carol Estabrooks, a lot of Carols at this conference, but they're smart, these Carols, as two just examples of two of the great folks that we have who've agreed to serve on this committee and bring a Western perspective as well. After we created our committees, we actually did a national survey and started conducting a literature review. And then we also did work on actually using the results of our survey to come up with more specific questions that we put out in town halls and consultation workbooks, for example. And all this accompanied our standard drafting that we did from between August and November. And then we reached consensus as a group to put out a draft standard for public review. And through our public review process, we are required to actually acknowledge every single comment that we receive, and then respond to those comments as we then go into our next phase of standard drafting that we're in the red, which will then help us create more detailed guidance and more specific criteria that will lead to the final draft standard that will be released in December of 2022. So it just gives you a sense of all the work that we do. And this follows the processes that are set out by the Federal Standards Council of Canada in order for having this work recognized as a true national standard of Canada. So I just wanted to just review that in our inaugural national survey, we had over 16,000 responses. And if you're interested in hearing what we heard, you can find that in our What We Heard report number 1 on our long-term care standards website. We then, as I said, did that phase 2 of consultation work, where again, we received hundreds of submissions from close to 2,000 individuals, including individuals who participate in our town halls. And all of those results are summarized in our What We Heard report number 2 that we released in January 2022. We just concluded our public review process. And through that, we had over 12,000 people who visited our public review website. We had close to 3,000 downloads of the draft standard. And we were proud that we received 435 specific submissions from both individuals and groups representing provincial or national organizations. And that yielded 2,452 specific comments. I know we have a few more that are coming in for people who asked for extensions to get their input in. We've had over 100 people support our town halls. And we're also doing resident interviews as well. And we've had over 43 participate in that, in addition to the over 350 who participated in our engagement work to date. So there's been a huge amount of public engagement, but that's actually really helped us develop a really strong draft standard. And these extra comments that we've now received, we've really welcomed, because they're telling us that we're on the right track, but there's obviously more work to do to be more specific, to be more directive, and to be more clear about our intent and the goals as well. So in terms of just giving you a sense of some of the things that we heard, we really heard that safety, reliability, and compassion are all components that equally create the provision of high quality care. And when we actually think about how people look at long-term care, we realize that there are 3 clear vantage points, if you will, from the perspective of residents, from the perspective of families, from the perspective of people who work in long-term care homes. And for residents, they want their long-term care homes to feel like homes, to look like homes, and they want care to be individualized to meet their specific needs. We have families that really talk about the importance of having transparency and trust in the care that their loved ones are receiving, and the care providers that are providing that care. And from our workforce perspective, we heard loud and clear that people working long-term care want to have the time to provide the care, and they want to feel valued, because as one of our technical committee members, Pat Armstrong, coined the phrase, the conditions of care are the conditions of work are the conditions of care. And so you really heard that as we had a strong focus on the needs of the workforce. When we think about the idea of long-term care, we often have to understand that it's often a really delicate balancing act, because there are many dualities that you have to balance, i.e. the idea, first of all, that long-term care homes are both homes, but they're also workplaces. So when we think about, from a home perspective, how do we think about this as it relates to daily activities, the relationships that people want to have with other residents, with staff, with their family members, and how do we actually think about the spaces in which we're providing care and support in a home-like environment. From a workplace standpoint, we often hear about the importance of having good leadership, having a good and positive workplace culture, and having hiring practices that really support a healthier workplace. And again, some of the things that we really had to define is what is a home versus a home-like setting, if you will. When we think about the dualities as well of long-term care, we think about also the idea of rights and safety and the idea of balancing the needs of the individuals versus the collective. So we think about the idea of resident rights and maximizing independence, respecting a resident's right to live with risk, and articulating the boundaries of individual rights. Because when we think about the collective, we have to think about how do we create environments where people can live free from harm, and that there are health and safety regulations that support workers and other residents as well. And so again, we also think about these notions of the term safety versus security, and how do we better define those. And then finally, when we think about balancing those approaches to care, I mentioned before about how residents want to have care individualized, often emphasizing resident voice, choice, and purpose, and thinking about care that is culturally safe and holistic and trauma-informed, and that really is collaborative in nature. But there's also a role for standardization, to ensure that there's some consistency and continuity, and that there are things that we can do in terms of collecting sociodemographic data and having good channels of communication that are, again, can be standardized in an important way. And apologies, you're hearing the hospital overhead interfering with my presentation. So finally, when we think about the foundational principles, I won't go through these in detail, just out of interest of time. But again, you will see that these are some of the key 6 principles that our technical committee came up with, that we really led at the start of our draft standard, that people could look at and understand what were the guiding principles that really underlay our standards. And right now, if you look at our standards, you'll find that it's currently divided in 10 sections. With 24 clauses and 183 specific criterion or statements that in future will actually be accompanied by detailed guidance that will help people to understand how they can actually action what that statement is actually saying as well. So you can still see a copy of our draft standard. You can take a look at that. I believe it's still available that you can take a look at and you can become familiar with. Obviously, with the feedback, we are going to be making adjustments to the criteria and then using that feedback to help better inform the guidance that we have. But hopefully this gives you a sense of how we're looking at things from a governance perspective, a resident-centered perspective, thinking about creating that safe home-like environment. How do we respect residents' rights? How do we think about quality of life and quality of care? And how do we think about coordinating care and integrating care that's provided within a home, but in a broader community, thinking about the workforce, and then also thinking about quality improvement as well. So this gives you, again, a sense of where we're at in the process. It's been a long journey so far, but a really rewarding one. We're just over a year into our work, but we're really confident that we've had a huge amount of feedback and support that will enable us to get where we need to go. So finally, I just want to finish off by saying we do have choices and options when it comes to thinking about how we look at long-term care. This is Ontario data right now, and Ontario notes that if you're waiting in a hospital to go elsewhere, the daily cost of being in what we call an alternate level of care individual, a person waiting in hospital to either go back to your own home or to go to a long-term care home, is about $750 a day. Care in a long-term care home costs about $200 a day, and care for a long-term care equivalent person currently costs us about $103 a day right now. So we know what it costs to provide care for people in a variety of settings. And I mentioned Denmark before, and some of you may have seen my adventure recently to Denmark with CBC Marketplace, where we actually really did a deep dive in terms of looking at what long-term care looks like and how they've approached their system. Because we noted that Denmark in the late 1980s avoided building any new long-term care beds for over 2 decades, and actually saw the closure of thousands of hospital beds by strategically investing more in their home and community care services. Home and community care services where you can get up to 8 visits a day, you can get up to 10 hours of care a day, where PSWs or frontline workers are actually trained to provide rehabilitation, where they're actually paid for their travel time. They're actually treated like human beings, frankly, and where you actually have a much stronger system, but where long-term care really looks like people living in spacious, kind of individual units, in accessible environments, but in a setting where workers also have the time to provide the care they need. So in the Ontario actually froze its hospital and physician budgets, and committed to at least a 5% increase in its home and community care budget between 2011 and 2018. And during that time, they only built 611 new beds. Our new current government that came into power in 2018 decided to actually decelerate those increases in the annual home and community care budget that had been previously up 5% a year. And instead has now made a move to commit to building 30,000 new long-term care beds. Under this new government, our long-term care waitlist now stands at over 40,000 people on the waitlist from 30,000 before, which then creates more demand for these 30,000 new beds. But I want to show you this data slide as kind of a picture is worth 1,000 words, and hopefully my pointer is working again, because basically, this tells the story of what happened in Ontario between 2007 and 2011 here. You'll see that the blue bars represent people who are 75 and older, who are long-term care eligible and being able to be supported at home with government-funded home care. Back in 2007, it was 42,000 people. While we had 75,000 people, and that number stayed constant over this time, pretty constant in terms of the number of older people who were living in our long-term care homes. During this time, the government of Ontario invested $1 billion in its aging at home strategy, which helped to bring up the number of people who could live in their own homes from 42,000 to about 60,000 people. In 2011, when I started leading the senior strategy, they then started increasing that home and community care budget by 5% a year. I basically said, keep going, keep going, keep going. And what you eventually saw was that by 2016-17, we actually had more people who were long-term care eligible being able to live in their own homes and communities than actually were even living in our long-term care homes. We were enabling more aging in the right place, for example. And clearly we need to make more of those investments to move that further ahead if we want to achieve something close to what has happened in Denmark. So a conversation needs to really begin at the federal, provincial, and territorial levels to determine how we should approach the future provision of long-term care and how to best enable aging in the right place for Canadians. National long-term care standards and a proposed national aging well at home benefit these are some of the things that have been recently announced, could be strong enablers. And while long neglected, the community support and home care sectors are more aligned than ever with what older people want and will demand moving forward and require greater attention investment. And promoting aging well will be one of the best things we can do to help many people avoid the need for long-term care in the future. And I think, again, if you take a note out of Denmark's book, they actually have a public health nurse come around to your home at the age of 80 just to check in on you and see if there are things they can help support you understand to help further age well in your own homes, to further delay needing long-term care at all. So again, some really good insights that I've hopefully shared with you from other countries, but again, showing you a path forward as well.